Bismillahirrahmanirrahim. Assalamu alaikum. Today our topic of discussion is about rheumatoid arthritis and its association with dry eyes. We will see how it happens, what are the clinical manifestations, how it can be investigated, and what are the possible treatments. Rheumatoid arthritis is a disease which is autoimmune in the nature, and its prevalence has increased a lot in recent decades. If we talk about the eye complications, and particularly about the dry eyes, it causes dry eyes by affecting the lacrimal gland. It also causes inflammation in the eyes, and also not only inside eye inflammation but also in the cornea. Dry eye basically happens because of the two reasons. Either the tears are not produced properly, or the tears are getting evaporated. So in rheumatoid arthritis, which is a disease of articular damage, cartilage damage in the different joints in the body, when it comes to the eye, the lacrimal gland is affected. And this lacrimal gland is responsible for production of 90% of the tear's volume. The outermost layer is the lipid layer. After this, the aqueous layers comes. The lipid layer is responsible for the prevention of evaporation. While when we talk about the second layer, in fact there are three layers. I am talking about the second, the middle layer, which is the 90%, which makes the most bulk of the tear's volume. When that layer is affected, its main chunk, its main part is produced by the lacrimal gland, and when that gland doesn't work, gets dysfunctional in rheumatoid arthritis, if we talk in our scientific language, the eye tear film homeostasis is disturbed significantly, because the 90% bulk of the tears has got lost over there. So today we will see how it happens in the patient suffering and how it can be investigated and treated. Are the corneal photographs? You must be thinking it looks different, blue color and green color. Yes, but this is what an eye doctor sees on special machines, which we use our biomicroscope, we call slit lamp ophthalmoscope, biomicroscope. And when we put an orange color dye in the eye and then we shine the blue color filter light, these are the green areas which are affected, which are damaged. The reason is, in these green dots there is no corneal epithelium. The epithelium is damaged. These spaces the dye picks up. These spaces pick up the orange color dye, which I will show you in the next slides. And when the dye stays over there and we put the blue light, it shows us the green. So it becomes very easy for the ophthalmologist to accurately localize which areas are damaged. So let's look at these slides. In these two slides, which is inferior portion, not superior, not middle, in fact the inferior portion, that cornea is taking up the stain and showing us the damage of the corneal epithelium. Why this is happening? Because there is minimal tears over there to protect the corneal surface. The two other photographs, again same procedure done. We have put fluorescein eye drops, and then we shine the blue filter light, and see in the one slide you will see extensive staining. The green stain is all over there, showing the extensive damage over there of the corneal epithelium. While the other side, it is not that much, but if you see in the center, there is minimal staining. To make it more clear, I have shown the two photographs, one with the stain and one is without the stain. The one without any stain, without blue light, eye looks normal. The patient comes, he complains of irritation in the eye, watering is happening, doctor, in my eyes, irritation. When I get up early in the my eyes are very dry and I have persistent irritation over there. I'm not feeling comfortable. So when the physician puts the fluorescein and stains, you can see the things become more evident and clear, and these stains are easily picked up. Simultaneously, in this and the previous slides, I will recommend you to please concentrate on the inferior, the lower lid margin, and especially there you will see a green line. This is the tear film margin inferiorly. When there is dryness over there, that inferior green line along the lower lid, its height decreases, its height becomes less, and usually it is somewhat convex. But in dry eyes, when 90% of the tear film aqueous part is getting disturbed, and there is evaporation also going over there, so it becomes concave. This line becomes concave. Its height, the green line inferior along the lower lid margins, its height starts decreasing. Again, to more corneal photographs, eye photographs. In one eye, the patient, we can say that he is having no apparent problem over there. But even if we do not use blue filter light and only put the fluorescein, it takes up stain and it shows us green, as in the green dots over there, and dye is shown along the lower lid margins inferiorly. So even without blue filter light, we can see the damage. Talking about the fluorescein, this is a fluorescein strip. It comes in the paper form and also in the drops form. If we use this fluorescein strip, first we have to put the local anesthetic drops, the minims I have shown, and after that, after topical anesthesia, these anesthetic drops, we put some and touch just the inferior part of the conjunctiva of eye, and the whole eye gets the stain and shows us the proper damaged areas. Up till now we have discussed about the use of fluorescein eye drops. These fluorescein drops basically show us quantitatively how much cornea is damaged, how much it is taking stain, what is the tear film height, when the first spot develops in the eye, whether it develops before 10 seconds or after 10 seconds, after putting the drops and blinking and opening the eye. Now we want to know about the production of aqueous part of the tears which is being produced by the lacrimal gland. Rheumatoid arthritis, a disease of autoimmune disease of articular cartilages, when it comes into the eye, it affects this lacrimal gland. Its production is decreased. Now what we can do is, we can do a test which is called a Schirmer test. And this test can be done with local anesthetic drops and without anesthetic drops. When it is done without, it gives us the total production of aqueous, which is being produced by the lacrimal glands and by the reflex from the inside of the eyeball. But when we put these drops, for example, these are the which are shown in the photograph also, when we put and then we do the Schirmer test, it tells us the proper production of aqueous part of the lacrimal gland purely. So how it is done? As I mentioned in the diagram, in the photograph, the local anesthetic drops are shown. These are anesthetic. We will put this one in the both eyes, and after putting these drops, as the eye is locally desensitized, we will take a Schirmer strip. In the packet comes 2 strips, one for the right eye, one for the left eye, and this is the, you can see here, I will show in the camera properly here. These are the strips. We will bend it from here, and after bending, we will just put it inferiorly here. Anesthetic drops are already there. Now we are putting it here, and then we will wait for the 5 minutes, purely 5 minutes, both eyes. And here you can see a blue line which is shown in the photograph also. If it will, after in 5 minutes it will start wetting this paper. This is a special paper. If we will do measurement after 5 minutes, if the wetting of this paper is more than 10 millimeter after 5 minutes, this shows that the patient has sufficient tears production. But if it is less than 10 millimeter and more than 5 millimeter, this is wrong. This is not good. The patient is suffering from dry eyes. And if even this patient is unable to reach this blue line, the 5 millimeter mark, it is less than that, it means he is suffering from severe dry eyes. So that was a point I wanted to discuss, the importance of Schirmer test in the evaluation of the dry eyes, particularly the lacrimal gland. As I mentioned earlier, the patient has dry eyes. There is less tear film over there. So it has to be substituted with something. That deficiency has to be made, and the compensation should be done over there. How it can be done? Of course, external use of the eye drops. Many types of eye drops comes. For example, one is the types of eye drops, we call it the drops form, which have to be used frequently. And in this we have hydroxy propyl methyl eye drops. They are used frequently. Then we have hyaluronic acid derivatives which are used. But as it is shown, these are preservative-free eye drops. So when we use these type of minims, they are not having any preservatives. So you can use it 4 hourly, 2 hourly, no problem with this. They don't have side effects, and they will make up the deficiency over there. They will restore the normal homeostasis of the eye, and will give a chance to eye to heal and repair over there. Because if there is no tears, if you do not put from outside, the eye is exposed to the atmosphere, the wind, the air, the temperature, the heat. There is no more protection, and it will get further and further damaged. So the first line of action in the dry eyes, when we are talking about, particularly about the rheumatoid arthritis, these preservative-free minims, they should be used as per the physician advice. They may be hyaluronic acid derivatives or hydroxypropyl methyl, hydroxypropyl cellulose derivatives. Their frequency is very important. They have to be put. But at the night time, when the patient is going to sleep, it is impractical to use the drops. At that time, we usually recommend the ointments or gels. Yes. They may be petrolatum derivatives, or they may be carbomers. So when the patient sleeps, we put it over there, so for long times of duration. But if patient is having severe dry eyes, I usually go in the use of these ointments and gels, even in the morning time, depending upon the situation, 2 to 3 times, and maybe sometimes more, depending upon the situation over there. So these are basically the lubricants, we call in our language, which are advised patients to use frequently. So when these minims are not available, the other option is the eye drops in the bottle form. The problem in this bottle form, there are some advantages and disadvantages. The advantages is that cost effectiveness. Once patient purchases the bottle, 15 ml, he can use it for a long time. But the problem is that no doubt it is relatively cheaper, but it has got a preservative, which is benzalkonium chloride. This is used in most of the ophthalmic solutions. The benzalkonium chloride in eye drops is used in 0.003% to 0.2% concentration, and it has to some extent antimicrobial effects. It increases the shelf life of these eye drops, and it can be used for long duration of the time. But it has been studied and it has been shown that these benzalkonium chloride, the preservatives, they can infect the first layer of the tear film, that is lipid layer, and then the aqueous layer is exposed. This benzalkonium chloride can itself cause irritation in the eyes. When these containers are kept for a long time, in spite of the antimicrobial properties of benzalkonium chloride, they can be contaminated. So these are, but at the same time, they are very much recommended. I'm not saying it that they cannot be used. Of course, we use it and these can be used, but they are not the first choice of the physician, but can be used. And if it has to be used, the use of these container drops should not be more than 6 times per day. This is the thing. While on the other hand, the preservative-free minims, they can be liberally used depending upon the situation. Now, talking about the rheumatoid arthritis, this is a lifelong battle of the patient, and we have to use all the available modalities and gadgets. This is one type of the gadget which is very helpful. These are the goggles with protective sides over there, shields and covers, and basically they protect the eyes from the atmosphere, wind, temperature, heat, and at the same time whatever moisture is there, they facilitate and help in retaining that one. So these goggles are also one option these patients can use. These goggles protect the eyes. These are covered from, these are not open as I used the other glasses. They cover the eyes from all over sides and they are also beneficial. So up till now we have discussed about the use of eye drops, ointments, protective goggles. Now we come towards some interventional things. If in spite of our all efforts, and along with this, nowadays we are also using the cyclosporine eye drops to control inflammation in the eyes. So they can also be used. But in spite of using all these things, if things are not getting under control, then we have to go for the intervention. And for the intervention, these are 2 photographs. These are called punctum plugs. And in the photograph, I have shown you that in the red circles, there are 2 punctum. Whatever the tears are produced in the eyes, in normal circumstances, they drain these 2 holes, which we call punctum, and ultimately they drain up into the nose. This is a system. This is called lacrimal drainage system. But now we are left with limited supply of eye drops. So what we are going to do is, we are going to put the punctal plugs. These are the plugs. They come in different sizes. And just putting the topical anesthetic drops. And after this, it is in office-based procedure. It hardly takes 2-3 minutes. And the beauty of these gadgets is that they temporarily block the punctal plugs, the puncti over there. And anytime we feel that the things are improving, these punctal plugs can be removed. This is temporary closure. But on the other hand, sometimes the situation is that much, the patient is developing big corneal ulcers and there is no hope. So by using the cautery methods, these puncti which are shown in the red circles, they can be permanently blocked and occluded and closed. So the reason is we have to use whatever the tears are available there. We cannot afford to lose it. So that's why this is another treatment modality. These were a few things which I just wanted to discuss with my respected audience about the evaluation and management of dry eyes in rheumatoid arthritis. And apart from this, these are the practical things which we are usually doing over there when things are even not happening and the ulcers have developed. Sometimes we have to close the upper and lower eyelids temporarily with the suturing over there. That's why called tarsorrhaphy, and then they can be opened up once the ulcers heal over there. This is advanced stages when things are really in the bad condition. And then much has been said about the use of the vitamins in the dry eyes. That is also debatable. And even the surgeons have tried to mobilize the parotid gland duct. Parotid gland is here a gland, its duct opens into the mouth, and they have tried to utilize that one, mobilization of parotid duct into the eye, but that is also not that much successful. So these were the practical things which we are doing over there, and it is a long procedure, lifelong problem, and the ophthalmologist has to work in close collaboration with the rheumatologists, and they work side by side to control this disease, because eye doesn't exist in isolation. It is part of human body. We in our terms call it the window of human body. Each and every disease which is affecting human body, its consequences, its side effects are reflected in the eye in one way or another. So we work with the medical specialists, and by doing this we can control this disease, we can minimize the damages, and patient can have a better quality of life. I hope my today's presentation will be beneficial for my respected audience in their clinical practice. I want to thank them for their attendance and attention. Thank you.